By the way, so we're going to move on to some questions here in a little bit, but if you'll pass your questions off to our staff members on the aisle there, we'll bring them on up and I'll start sorting through that. Dr. Bochner, I meant to ask you this before. Can a cystectomy, this radical cystectomy, because people always ask, can this be done laparoscopically, minimally invasively, or is it really too big a procedure?
Yeah, no, there are surgical tools that allow us to approach this procedure with smaller instruments that can be placed through smaller incisions. A portion of the procedure can be done using these techniques, whether we hold directly onto the instruments, which is called laparoscopy, or if we attach these instruments to a machine and then we operate the machine, a robot-assisted laparoscopic procedure. You can do this procedure effectively. We still have to do the reconstruction typically through an incision, so there's usually an incision associated with the procedure either way. The question as to the benefit for patients is still being sorted out at this point. It is a large procedure. We'd like to think these minimally invasive techniques allow patients to heal quicker, have fewer complications, get back to their life activities faster. But there really hasn't been any evidence pointing to that yet. We happen to have one of the very few studies here in the country that are developing that kind of data. It's a randomized study that's taking patients that are headed for surgery and we're assigning them, randomizing them to either the standard open approach or this hybrid robotic versus open approach in hopes that we can establish exactly how it should be used to help patients. So, but if I could just quickly kind of expand out on something Dr. Kohlmeyer had just presented, I think that she had presented this sort of novel combined approach for radiation therapy. It's a perfect example of the coordination that occurs at an institution like this, where not only the reason that I was brought to this center is the quality of the colleagues that I get to work with, and quality of care obviously is critical, but the coordination of care is also a very important aspect to make sure that you see all the people that you need to see in a timely fashion, and you kind of get moved on to therapy. And obviously the other critical thing is having availability of all the options for treatment, not only the standard options that we've discussed today, surgery, radiation, chemotherapy, but you also have access to the latest drugs, the latest techniques. Dr. Bochner is recognized internationally as a leader in developing new trials for drugs, and as Marissa said, these techniques that she's using are really kind of cutting edge techniques and escalating doses to try and optimize therapy. So, there's a variety of reasons that people are drawn to this center, and I think that some of the things you've heard really exemplify why it's of benefit to come here.
And Dr. Bochner, we're going to talk about drugs and clinical trials and such here in a minute, but Dr. Bochner, as long as you mentioned reconstruction, and I think that's the big issue. I think that people who are going to end up having a cystectomy, have their bladder and other associated structures removed, their big question is, obviously, I'm going to keep making urine. Where does it go? What do I do? Am I going to have a bag, an appliance?
Absolutely.
What happens?
And
what are the options?
And how is that going to affect my ability to live my life?
Mm-hmm.
So now there are a variety of options to reconstruct the systems that will allow people basically to get back to all of their normal activities. It really at this point is not a stretch for me to sit down with a patient and say, after surgery, everything goes as planned, we would expect you basically to return to all of the activities that you're doing now. And so this may require an external diversion, a stoma, an opening on the abdominal wall where an appliance or a bag would collect the urine. This sits underneath the patient's clothing and is usually not visible to anybody unless they want to show it to them. But there are also internal reconstructions that can be put together using parts of the intestinal system. These can build reservoirs that store the urine inside. They can be hooked to the urethra, the tube leading out to the exterior, such that a patient can store the urine and volitionally void like they would with their normal bladder. Or reservoirs can be built connected to the abdominal wall that may require catheterizations. But these internal reservoirs obviously eliminate the need for the external device. These are not new reconstructive options. We've been doing these for decades at this point and have worked out many of the issues related to restoring that functional aspect, the control aspect. So I think that in 2012 that we now have several options that are available to get people back to full functioning lives after surgery.